roll, if you, in the meantime, could look at the board meeting minutes for approval, I'd appreciate that. I'm just going to straight call the list. So I see that Tom's here. I see
Here.
Bob Stewart, Susan Reiki Smith. I see
Here.
yes. Susan Miller. Okay. Come back to that one. Bonnie. Okay. Bill Grupp. He's here. Enrique. Michelle. Jeff.
Yo.
Okay, and I see JJ and I'm here. So we have 4 who are currently not here. Ali, we have a quorum, do we not?
We do.
Okay, well, we will proceed then. So on the agenda for this particular board meeting, our next step is to approve the board meeting minutes from May 2nd, 2023.
Move to approve.
Second.
Jade. Who was the second? Sorry.
Bob.
Okay, thank you, Bob. All those in favor of approving the board minutes as written, signify by saying aye.
Aye.
Good. Any nays? Okay, thank you for passing the minutes. All right, so we are getting to the next section, which is the election of board officers. All right, so in accordance with Section 9 of the OEBB bylaws, which you should have received earlier today, the election or reaffirmation of officers occurs every year. As my 2-year stint as the OEBB board chair is ending, I would like to thank all of you for. Sorry, just got really bad feedback there. I'd like to thank you for letting me be the board chair and letting me participate in the good work that we do to make sure that everyone's covered in the most equitable, fair, and efficient and economical way. So I'll call on for a motion to appoint JJ Schofield as the new OEBB board chair, effective immediately as the current vice president. Okay, so I will entertain. I would like to entertain candidates to serve as the OEBB vice chair. I'm sorry, I messed that up. Sorry about that. I would like to
promotion. All right.
See if we, yeah, I would like to see if there's a motion to appoint JJ as the next board chair of OEBB.
So moved. This is Tom.
And this
motion by Tom. Okay, second by Susan Reiki Smith. All those in favor of appointing JJ Schofield as the next board chair in pursuance of the OEBB bylaws signify by saying aye.
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 Any nays? Okay, motion passes, and JJ, thank you for volunteering to become the next OEBB board chair. And so now, JJ, if you could please call for candidates to serve as the OEBB vice chair, please.
Thank you. So according to the bylaws, candidates must be from different stakeholder groups. I am from local government management, so it needs to be from either union groups or the healthcare subject matter experts. So I'm looking for a motion to appoint someone as the vice chair.
Well, I will move to appoint Tom Siltabo.
I have a motion. Do I have a second?
I'll second.
I'll second. It's Bill. As long as Tom agrees.
I agree.
All right, excellent. I have a motion and a second. Let's take it to a vote. So all those in favor say aye.
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 All right. Any nays? Hearing none. Awesome, Tom. you are the next vice chair. That is terrific. I have
Ali,
I
you
have a
have your
little
hand
hand up from Ali. Go ahead, Ali.
Oh, I just want to take the opportunity to congratulate JJ and really to honor Robert and thank Robert. It's really just been a pleasure working with him over the last couple of years as chair. And, he has always brought such a positive energy to the board and to meetings and just been very kind and pleasant to presenters. And I think that you wouldn't be able to tell Robert's stakeholder representation. I think, that's obviously what we look for in a board member and a board leadership position. I think that, not to mention that, but he actually nailed his Ways and Means presentation, which was very impressive and has just been dedicated a tremendous amount of time to the board, to staff, and has never taken issue with the amount of time. And we just really appreciate you, Robert. Thank you.
Thanks, Ali.
I agree.
Yeah, I just want to say that I agree too. I can't say any better than Ali just said it, but Robert, really appreciated you as chair. Good job.
Thanks, everyone.
I agree, Robert. Thank you so much. All right, so moving on. Next, we have open enrollment compensation plan update, and I believe Erin is going to be presenting that.
Yes, I am, but Cindy Bowman is going to kick things off for us.
All right, go ahead.
Hello, everyone. Jackie is on vacation. I know she'd want to be part of this too, but she decided to take a week off instead. I just wanted to acknowledge all of the work that the Mercer Communications team has done. As you know, you as the board have really emphasized the need to educate our members and to make sure we're communicating clearly the benefits that you as the board have approved for them. So I think you're going to be pleasantly surprised, maybe not so surprised, but very pleased with the work that the Mercer team has done. We have some new digital tools that we're going to roll out this year for open enrollment. And that's what Erin's going to go through with you. We are looking for your feedback, hopefully positive, but if you have some constructive feedback for us, we welcome that too. So I will just let Erin take it from there. She did let me know that she's kind of suffering a little from a cold. So if she needs to pause for a cough, or you just bear with her, please. So
thank you,
Erin.
Cindy. Thank you. All right. So if we move to the next slide, what we plan to cover today is we want to take a look at the open enrollment communications that are planned at a glance. And then we also want to take a closer look at the digital tools that will be available. So this includes a new digital plan comparison tool, Explore Your Benefits, which is an interactive learning module, and then also the virtual benefits fair. So I'll be able to demo a couple of those for you, and then we have some concepts also to share. So I'll start those after we go through the communications at a glance. So if we go to the next slide, you'll see all the communications that are planned over the next several months. We started with May, and we're showing everything through enrollment. In May, there was an announcement email to entities that went out on May 5th that also included a benefit summary. So this was a summary of the medical, dental, and vision plans. So those two things went out together on May 5th. And then there was a summary of changes for stakeholders, and this summarized all of the decisions the board had made for the 23-24 plan year. Now we're into June. And so for mid-June, we're targeting to have the digital plan comparison tool go live. And I will demo this for you, but this is going to be a new tool. It's going to take that benefit summary PDF and put it into an online format so that members and administrators can go in and compare the plans. You can, look at specific plans, you can look at specific services, you can print it out. And we think it will be a great tool for users to be able to look at their specific plans that are available to them. OEB is also planning for posters, and the hope is that we'll be able to do like print and ship. So you could start ordering your posters in mid-June, and then those posters would arrive in mid-July. If we move into July, the third column there, we're planning a sneak peek email to members, and this will outline the plan enhancements and changes for 23-24. That will be an email, and then you'll be able to link from that email to the benefits guide, where there will be more information about those enhancements. Also, the website will be updated. OEB's website will be updated to include the information for the next plan year. We're also going to be doing things like there's some videos that are on the site that are kind of hard to find right now, so we want to elevate those and make them more visible for members, updating the required notices, etc. And did I hear a question? Okay, please jump in if you do have a question. And then last in July, there is a heads up postcard. So that's a postcard that goes to members' homes to let them know that open enrollment is coming. And so that is targeted to go out in late July. Now, in moving into early August, we plan to launch the Explore Your Benefits tool. The target right now is August 1st. And this is the interactive learning module that I mentioned. And it will cover the medical plans, dental plans, all of the optional benefits in detail. It's a combination of videos that are available for watching, some gamification, so you can take some quizzes, earn some points and prizes, not prizes, I should say badges. And we're exploring potentially linking that to some kind of charitable donation to encourage people to participate and use that tool to learn more about the OEB benefits that are available to them. We also will have the virtual benefits fair launching in early August. It happened last year for the first time, so this will be the second time that the virtual benefits fair will be available. All the information will be updated for 2023-2024. It will have all the webinars from the vendor partners. We're also exploring being able to sign up for one-on-one meetings with the carriers, so you can do all that through the virtual benefits fair. And then last but not least, in early August is packets being sent to members' homes. So this will be an envelope and there'll be a personalized cover letter in it. The cover letter outlines which plans are available to the member. And then for self-pay retirees, that packet will also include a rate sheet. And then once we get into open enrollment starts August 15th and ends September 15th for most members. Some employers do close it earlier than that. Oops, sorry. Can we go back one slide? Thank you. We'll have the mandatory OE postcard. So that mails out August 15th, but essentially letting people know that you are required to make elections during open enrollment. The open enrollment webinar, so this is the webinar that's conducted by OEB and includes the vendor partners. That will be available in mid-August. Reminder emails will be sent throughout the open enrollment period. And then once you submit your enrollment elections, then you get a confirmation email. And those emails are sent out daily once people submit their decisions. And then for paper letters, if someone elects a paper letter, then that mails out in late September. And then last but not least, we have post-enrollment. In late September, the 12-month wait letter goes out, and this is related to the 12-month wait period for those who did not sign up for dental coverage when initially eligible. So any questions? This is at a glance. Any questions about what you're seeing here? If not, I will jump into the digital tools and talk about those in more detail. So let's move to the next slide. Thank you. So this is the digital plan comparison tool. So we've included some screenshots here, but ultimately with this tool, you'll be able to compare all the important plan features for the medical, dental, and vision plans. You'll be able to understand the specific services and how they're covered. You can print out your comparison. And this year we are continuing to offer the PDF or summary, but in future plan years, we plan to not offer that and just have the digital tool here that you're seeing. It's a fairly simple tool to to use. You enter the site, you click the start the plan. When you're into step 2, you can designate which plans you want to look at, which services you want to look at. You click next step, and then you see all the comparisons. And once you're on that full comparison page, you're also able to collapse columns or collapse rows. And I'll go through all of these, and then I'll take you on a demo of this one so you can see that new tool that's been built. If we move to the next slide, this is Explore Your Benefits, and this is the interactive benefits learning tool that we are creating. So this one I'm not able to show a demo of it because we are really in the process of building it. We're working on the content as well as the graphics. But I did include some screenshots here so you can get an idea of what the tool will look like in terms of the graphics. The big image that's there on the bottom is going to be the home page. So you'll be able to click on those different signs to be able to enter into the different modules. Once you get into it, you can see that vision, it's in the top middle there. That's where you can get into more detail around content. There's a webinar for each section. There's a quiz from each section. Some sections also have some wellness, additional wellness like quizzes. And then there's also a section for each of the carriers under each benefit. So that's where in that you would click like on MODA or Kaiser or VSP. The screenshot on the top right there shows what a video looks like. So that box automatically pops up and you start the video to play it, and it gives you an overview of everything. If you look on the bottom in the middle, that shows a screenshot of if you had clicked on the MODA, you would get specific information about MODA, and you'd be able to then browse those key features and collapse those boxes to get more information. And then the last screenshot there in the bottom right corner is for those wellness badges. So for the sections that have wellness, quizzes or challenges, you can earn the wellness badges as well. So we're really excited about this. It's going to be very comprehensive, very interactive. It has that gamification angle to it. So this is something we're really pleased to roll out this year. And then if we go to the next page, this is the virtual benefits fair. And like I said, this is going to be year 2 of the virtual benefits fair. I included some screenshots of what the fair looked like last year. So there was the lobby that you entered into, and from there you could go into the benefits enrollment center or the auditorium where you could access the different webinar, the vendor partner webinars. You could go into the exhibit hall where you could then find the vendor booths and get the different information. There was also a wellness resource center, and we do work with the vendor partners to populate all the content within this. So, for example, that you're seeing in the top right corner there, a booth for Kaiser, and all of this content comes from Kaiser. And this year we plan to show it. We'll have it in both English and Spanish. Last year we didn't have necessarily everything in English and Spanish, but this year will be. If we don't have it in Spanish, we're also not including it in English. So we're making sure that it's going to be accessible for both groups. And then I also mentioned that we're planning to offer one-on-one appointments with vendor partners. We're exploring with them. Some of them use a software called like Sign Up Genius or something else. And so we're going to make that available to members so that they can sign up for individual appointments to connect with vendor partners. So any questions about these? If not, I will jump into a demo of the digital plan comparison tool as well as the virtual benefits fair. All right. So then if Rose, if you're sharing, if you wouldn't mind stop sharing so that I can share my screen, that'd be great. Thank you. All right. Okay. So I'll do the virtual benefits fair first. Are y'all seeing that on my screen? Yep. Okay, super. Thank you. So this is the virtual benefits fair. So you saw these screenshots in here, but it really is easy to navigate throughout the site. If I were to click on here, it would launch a welcome video. I could also go into the exhibit hall. And once you're into the exhibit hall, you can go to the different booths. Here we have the medical, dental, vision booths. If I click on more booths, we would get into like some of those optional services. And then we also have booths for the wellness partners. Now this year we're gonna redo this part a little bit so that you go to kind of more one screen, so you don't have to navigate, you don't have to go like back and forth like this. So we're gonna make that an easier experience for members. But I will click into MODA here for medical just so you can see. Now that screenshot that I had included on the deck was for Kaiser. This one is here for Modi. So you can see that all the booths look relatively the same. We wanted to keep that consistent, but we change up the people in the booths. And then certainly all of the content that you can link to within the booth is provided directly by the vendor partner. We also make sure that we have the contact information here within each booth to be able to, so people can get to that right away. I'm going to go back to the lobby and go into the auditorium. So this is where the auditorium is where you can access the different webinars from the vendor partners. So for example, here's like the Delta Dental presentation, and then, it starts playing it. If I click this, I won't click it for you, but from right here, you can access it. We do also typically include the OEB webinar, the open enrollment webinar that's created each year. So this is, you're able to access that from this auditorium as well. And I will go into like the wellness center, just so you can see that. So we have all of the wellness resources here called out specifically. And then we have a benefit enrollment center up here as well. This year, we are adding also a special room for emotional well-being. So we're asking the vendor partners to provide specific resources that we can, or that touch on emotional well-being. And we plan to organize the content by topic. So things like depression, anxiety, so that based on how you're feeling or the information that you need, you'll be able to locate that easily. We're also going to be giving the virtual benefits fair a facelift. So the organization will be the same, but we'll be having new pictures outside. The colors are going to change. We're adding, I think, some brick and some green. So it's going to have a different look and feel. So we'll know that it's different from the current virtual benefits fair. So any questions about this before I move to the plan comparison tool demo?
Tom?
Oh, Tom, yes.
What is the expectation or hope for the number of people who will use this virtual benefit fair?
That's a good question. Cindy, do you want to take that? Do you want me to answer?
Well, if you have an estimate of how many attended last year, that would be good. The intention with this was to replace, of course, during COVID, we couldn't have the in-person fairs anymore. And so we were looking for an alternative so members could still get that same experience. Erin might have the numbers that we have for last year. We're really trying to promote it so that, for one thing, we do the open enrollment webinar each year, and that used to include each of the carrier videos as part of that. So we had a lot of members tune in for that webinar, and they would sit through the whole thing to get to their carrier's video, for instance. So we're doing that.
And I think it's a brilliant idea. I think it's a brilliant idea. I remember going to benefit fairs before, and not many people were able to participate. Not many people came, and I think it was just the difficulty of finding time and all of that. I just would like to. It'd be great to understand how many people are using it, and almost if we could identify them, find out what was good, what wasn't, and how to improve.
Mm-hmm. And Tom, I apologize. I don't have the number with me readily
That's
available,
cool.
but I can follow up with it.
Yeah. It's just interesting. I mean, because it's not everybody needs it, but the people, it'd just be nice to know. That's all.
Mm-hmm. And my answer is we want more than last year. Is my general answer.
Yeah.
And Erin, didn't we do a survey at the end of last year and ask for feedback about it?
I'm not sure.
That,
yes, I'm not sure. I think we might have asked about it. Did we ask about it in the member services survey? I'm not sure. That's something for me to check as well, because we could also add a survey to it somewhere, give us your feedback about this, because love to hear the feedback from
Yeah.
members about how to improve or things to add, something they'd like to see.
Yeah.
That would be great. So Cindy, I'll take those 2 questions back, and we can follow up. Okay. Good. Thanks, Tom.
Yeah.
All right. So I'll jump to the plan comparison tool now. Hopefully you all saw that change on my computer. But this is the digital plan comparison tool. You come to this homepage here, and to start, you click on this button. You come to the next page. Oh, sorry, it's taking a minute. Where you can check the different services that you want to see. There's a table for medical, a table for dental, a table for vision. I'm going to just show everything so you can see it. But once you click on to next steps, then you'll see the comparison of all of the plans. So here, first it shows medical. So you can see all the Kaiser plans here. So plan 1, in and out of network, plan 2A, in and out of network, etc. And then you can also see the MODA as you scroll to the right. Now you do have to scroll because obviously we're showing every plan right now, but I can choose to, like if I don't want to see plan 3 or I'm not eligible for plan 3, I can collapse that. So I don't see that. And then I can really just show the plans that I'm eligible for. To get those plans back, you just click show all plans and you can see they reappeared here. The other thing that you can do is collapse by the different services. So if I were to click on this medical network, it would close that whole section, or I could close a specific service within a section. But again, if I closed anything, I could click on this show all services and they would all pop back up. The functionality for the dental and vision is the same. I'll just scroll down so you can see that. But here's the dental chart. So you can see the Delta dental plans have the green headlines. The Kaiser plan is blue, which is the same color we used up in the medical. And then for the Willamette Dental Group, it's this, I guess, aqua color, turquoise color that matches their logo. And then last but not least, we have the vision at the bottom. So you can see the Kaiser plan, you can see the 3 MODA plans, and then the VSP plans here. And again, with all of these, you can collapse whichever columns you'd like. You can collapse whatever rows you'd like. And then based on whatever you're looking at, you can choose to print. The print button is here at the top of all of the tables. We do have a note here that we recommend that you print no more than 18 columns because just what fits on a piece of paper. And we also recommend looking at it or printing it in a landscape layout. But the printout is nice so that you can just, again, see the plans that you specifically want to look at and the services. So Cindy, anything else you want to highlight about the plan comparison tool?
I don't think so, unless people have questions.
I did just think of something, sorry.
Oh, no, that's okay. I was just going to say that we do get feedback from members that it's a challenge for them to use the paper version and try to compare what plans, because so many of them only have a handful of plans available to them. So we're hopeful that this is going to be really useful for members. Go ahead, Erin.
Thanks. I was going to add that right now oh, sorry. Can you hear me? Okay. Okay, super. Right now you're looking at the English version, but we are working on the Spanish version. And so then members will be able to choose if they would like to view it as in English or Spanish. So that will be an option. And I know Jackie did, I think, bring it up for some benefit administrators recently, and I know she got really positive feedback about it. They're excited to be able to look at specific plans side by side. All right. So any questions about this tool? All right, well, that is all we had to share today, unless there are any questions.
Thank you so much for that presentation. Again, the benefit conference thing, I don't know how it'll be received, but I think it's a very creative and innovative approach. So kudos to you on that.
Great.
All right, moving forward, we have an EAP request for information update. John?
I think you're on mute, John.
Thank you, Ali. So yes, that's always the challenge, trying to get the camera and the mic off at the same time. So appreciate that heads up. So again, thank you for having us speak on this important topic this afternoon. We just have a couple of slides, and we'll dive right in. So next slide. So, and again, on the performance issues, we weren't looking to be comprehensive. We're kind of trying to find, general categories where the issues were, with Uprise earlier in the year. So I think, one general category is responsiveness. This was experienced by members in terms of long, callback times, when they're trying to access services. The OEB entities also had some challenges that were particularly concerning around critical incidents response timing. And then OEB and OHA, staff also had some challenges. Some of these challenges that I've highlighted here relate back to last year's open enrollment, around getting materials and getting Uprise representatives to open enrollment meetings. So those are the topics in terms of responsiveness. In terms of access, we have the providers not accepting new patients. And I think it's important in fairness to point out that this is not something that is unique to Uprise, but it's really more of an industry challenge. There's more demand than there are providers available to meet that demand. We met with Uprise early this year, and they have taken actions to address these performance issues, and we'll briefly go through those. Many of those are already complete, some are in process, and some are down the road a little bit as well. So Uprise did create a critical incident response team. They also took measures to streamline that process. So I think hopefully that there's better understanding among all parties about how to request critical incidents response team. And they also looked at the member service. They assembled a member services SWAT team to really understand what the challenges were. A lot of this effort has been focused around improving first call resolution. So, instead of having to call back members, resolving it on the first call when they call in, and not having it need to be addressed later. And also there's been improvements in reducing callback times, actually pretty significant improvement, to getting back to members. And I think that what you're seeing too is that they're really rethinking their intake process, to really have their clinicians operate at the top of their license. So they're, using, intake people that aren't clinicians to help people find appointments rather than the clinicians spending their time on that. So really just rethinking their process. As a part of rethinking their process, they're also looking to, upgrade their call system. So Uprise is really the combination of several legacy organizations that had their own call systems. So, later this year in Q3, they'll be looking to consolidate and modernize their call systems. And again, this facilitates the next bullet, which is the improving of the member experience reporting, which will come towards the end of this year. And another effort around access is really their, overall country nationwide. Uprise is looking to add 10,000 providers this year. Again, not all in Oregon, but that's their national number, and so they're looking for opportunities to and looking for specific providers that might be added in the Oregon market that would help alleviate some of the access challenges that OEB members have experienced. Any questions or comments? JJ?
Yeah, just a quick thing, just to, I know when we got an update from them last time, they sort of finagled the numbers where they would say, here's the total number of calls. And they made it appear as though each of those calls was another member, and it wasn't, because many of the calls would be multiple calls from the same member. So, one person may access the service 5 times, and they viewed that as 5 different incidents, and made it seem as though they were helping a larger percentage of our workforce. So when we get some of this response, I just want to make sure that we let them know on the front end that there will be some pushback if they try to sort of finagle numbers again.
Understood. Yeah, we'll convey that to them so they understand that. So any other comments? So as a result of these performance issues, the board had requested that Mercer undertake a EAP request for information, and that's what we're going to go through next. So next page, please. So here's really a high-level summary of what we found in that RFI process, that we reached out to 4 vendors. And, again, a lot of our questioning was centered around, 4 key areas: implementation and transition, member experience, access to care and network, and diversity and inclusion. And these were things that were identified as priorities by OEBB. In terms of implementation itself, so we identified 4 EAP vendors that could definitely deliver on the needs of OEBB. All of them confirmed their ability to replicate current benefits. They had implementation timeframes from 30 to 90 days. And they also had, measures to improve the transition from one EAP to another. So that includes things like single case agreements. And what that is essentially reaching out to providers who aren't contracted, and writing a kind of a contract just for that case to resolve that, the care for that person. Also coordination between providers, coordination of care in terms of the transition, and then communication support. In terms of vendor capabilities, these are really kind of the table stakes types of things in terms of capabilities. So it's, 24/7 availability of call center, assistance with scheduling, because again, access is one of the key challenges. And again, understanding, some of the challenges differ between if you're looking for a online appointment, is going to be easier than if you're looking for something in person. Looking for diverse, provider networks. Some of the vendors had the ability for online scheduling. Again, I think this is something that's going to be particularly important going forward. And then also one of the other capabilities that is table stakes is really around this, self-service education and resources. So let me just pause there quickly, see if there are any questions, comments. Okay. So the next slide is really a summary of of what we found in the various key areas that were of interest to OEBB. So in terms of implementation and transition, the 4 areas that we looked at, you can see here. And in the first 3 areas around implementation support and transition of care, and the transition communication support, and the ability to administer the current design, you see all of the vendors that we reached out to, have that ability. Where you see some differentiation in terms of is what their potential time period for implementation for OEBB would be. So 3, as you can see here, 3 vendors, 3 of the 4 said 30 days, 1 said 60 to 90 days. Frankly, I think trying to do this in 30 days would be not advisable. But again, these are their responses. Diving into the member experience, is the initial call answered by a clinician? That's all 4 had that. All 4 had call centers that were available 24/7. Half of them had online scheduling available. And then all of them offered scheduling assistance, which is, I think from everybody's perspective is a critical need these days. just making sure that you can get an appointment. Moving on to access of care and network. Here's some of the timed appointments. So one had 3 business days, and 2 had 5 business days, and 1 had 5 to 7 business days. And again, this is average book of business, and this could differ for the Oregon market. I think that's important to recognize, especially in those areas where there are a bit of provider deserts. Provider availability is verified. 3 out of the 4 did that. Just because a provider is in your network doesn't necessarily mean they have availability. So, this is really an extra step that a lot of vendors are starting to do, as you can see here, is reaching out to confirm that they actually are have appointment availability. And then I think, the next piece is the future really is, providers have connected calendars. And here you're seeing there are two of the vendors had some, 15 and 30% of providers respectively had this capability today. Again, just something that's evolving. With regards to diversity and inclusion, half of the EAPs that we reach out to are collecting that data, that's necessary to be able to report on these different cuts. The other piece is and then so it's really collecting and reporting on it. So I think that's the next one is 3 out of the 4 said they are able to report on it. And then this last one is around web content, and access guidelines. That's what the WCAG stands for. And this is really just, are they building a website that keeps the needs of the disabled in mind in terms of how it's been developed. So, and fortunately, you see here, all of the vendors had this ability. So I think, to sum things up, there are definitely vendors out there that could serve the needs of OEB, and probably better in some areas, same in others as what you have today. But again, I think this kind of confirms that there are options available, should there be a need for them. Any questions or comments? Okay. If that's the case, I'll, again, thank you for your attention. Oh, Robert?
Yes. So what's the timeline on the next steps on this?
I think that's really up to the board in terms of, how they choose to proceed at this point. In terms of, because again, Uprise has been renewed for next year at this point. Ali?
Yeah, I can make a brief comment. We're working on our RFP prioritization, and we'll be setting up some time this summer with our new board leadership team to prepare for a fall retreat. This will be part of the discussion. So I think, as far as next steps, I think that's probably the most logical next step.
Okay. So at that point, I'm gonna thank you for your attention, and thank you, Rose, for the slides. Appreciate it.
All right, thank you very much. We're a little ahead of schedule. That's great. Next, we have budget update from Ali.
Yeah, thanks, JJ. Okay, so today we'll be looking at our semi-annual budget and financial update. We'll be looking at 3 areas. We'll look at the status of OEB's 2021-2023 legislatively approved biennial budget. Second, we'll take a historical look at our claims paid over the last 4 years and how it's impacted our funding position, specifically with MODA. And third, we'll take a look at our cash reserves. We've talked a little bit about that in previous board meetings. These are also known as our stabilization funds. So you might remember last fall when we did a deeper dive into the minimum premium arrangement with MODA and explore the reserves in greater detail. This report will serve as more of a status update. You also might remember that Kaiser plans are a more typical fully funded, fully insured plan and funding model, whereas OEB passes through premiums collected over to Kaiser, and this is much different than the minimum premium funding model we have with OEB. Next slide, please. So kicking this off, let's look at the 21-23 biennial budget status. Glenn Bailey will give a legislative update in a little bit and talk a little bit about the chaos right now with the legislature. And we think we're okay budgetarily, but we can discuss that a little bit later. This report is reported through March of 2023, which is 88% lapsed through the biennium. Or 21 of 24 months reported. And on the slide, you'll see our two budget structures, the stabilization budget, which is $1.9 billion, and our operations budget, which is $22.8 million. So 99% stabilization and 1% in operations. The stabilization fund budget captures all expenditures going out to carriers for benefits and claims costs. After bringing in premiums from participating entities and self-pays like retirees and COBRA members. The operating budget captures expenditures for staff personnel costs, consultant costs, system maintenance costs, and other operating expenses. And as you can see in the stabilization fund chart, through 88% of the biennium, we have expended about 84.7% of our budget, so well under. And the same holds true for operations, where we've only expended 63% of our biennial budget. So we look like we're in good shape. Next slide, please. On the next two slides, we'll take a look at the MODA dental and medical claims fluctuation over the past few plan years and take a partial look at 2022 and 2023 through 6 months. Starting with our dental claims on this slide, you can reference the two bars as the maximum claims liability, which is also known as our minimum premium arrangement. And you can look at that as the premium. The next bar over is the gross adjusted claims, which are the total claims paid out net any adjustments, and view that as an expenditure. So for example, in the 17-18 plan year, we collected more in premiums than we paid out in claims, which result in a surplus position. The line represented is the claims liability balance, which basically means any balance for the year. So in fact, a surplus was realized in every year on this chart. So you can really see the level of claims drop off in 19 and through 21 plan years. So far we're in a slight surplus for the 22-23 plan year through 6 months. Next slide, please. So this is our medical claims. We'll get into the terminology again. It's premiums versus claims at a simplified level. And you'll notice that we had a deficit in plan years 17, 18, and 18, 19. This is where we paid out more in claims than received in premiums. This turned around into surpluses in 19, 20, again through 21, 22, and again through 6 months in 22, 23. This is pretty consistent with PEB self-insured plans, and you could even call minimum premium arrangement a quasi self-insured funding model, but so far we've moved OEB into surplus territory, which we'll talk about more on the next slide. But it's really the first time that OEB's been in a surplus position, so that's really great. Next slide, please. So this last slide shows our reserve cash balance reported through March of 2023, which sits at 60.2 million. And this is comprised mainly of two pots of money, the rate stabilization reserve funds, also known as RSR, at 20.9 million, which was generated from Senate Bill 1067 hospital cap savings. And then the OEB stabilization reserve, which has slowly been built up over the years with interest earnings, administrative budget savings, which we'll see some this year with our operating savings, and then even some federal investment funds. The RSR reserve and stabilization fund reserve is much different than the medical and dental cumulative claims liability balance, which we noted at the bottom of 87.5 million. This is noted, really, we're in a surplus position right now, but claims payments fluctuate dramatically month to month, and that balance is subject to claims run out upon termination of the contract, which is why I kind of hesitate even putting it on the reserve category, but we wanted to note it somewhere. And we will explore the medical and dental cumulative claims reserve at our fall retreats when we talk about our 3 to 5 year strategic planning and where OEB sits financially and looks at areas for investment. So with that, I'd be happy to entertain any questions.
Seeing none, thank you, Ollie. That's very helpful.
You bet.
Oh, we have one, Tom?
Yeah, the question has to do with the paying for the system, accounting system upgrade, the membership system. That comes out of the operating budget. And how much of that money is subscribed as such to pay for that, a system upgrade?
Yeah, really, the funding for the new system has come from administrative savings over the years, which is great. We didn't have to borrow any money or issue COP funding to do that. I can provide the board with a breakdown of, it's kind of been extended over 3 to 4 years of kind of year over year what the budget has been, what the expenditures have been, and kind of where we're at status wise with that.
Rolling it into the overall budget conversation at the retreat is fine. I was just interested.
Okay.
Thank you.
Yeah, you bet.
All right, anyone else have any other questions? All right, hearing none, let's move on to the legislative update. Glenn?
Thank you, JJ. Ali gave a pretty good lead in by saying the chaos, if you want to use that term, in the legislature. I won't talk very much because I think you folks have seen probably in the news about what's going on. A number of Republicans and an independent since May have, in the Senate, have basically boycotted the floor session, so no bills are in right now moving out of the Senate. That said, committee work is still being done. The policy committees finished in May 19th, all their work. Right now, we're looking at the Ways and Means Committee and its subcommittees. They are now working on bills that have been referred. And usually, when a bill is assigned to one of the Ways and Means subcommittees, it is an indication that they want to move that bill. So we are providing more information if required, and just keep monitoring those bills. They then go from the Ways and Means to the chambers, usually to the referring one, which would, in many cases, the House. And then right now, constitutional sine die is June 25th. There has not been any official word what's going to happen afterwards. A number of scenarios have been put out there, but really no official words. So what I wanted to do is literally kind of give you, based on what's currently happening in the legislature, kind of a breakdown of our bills and pretty much where overall they're at. So you can kind of get a sense of what some of these problems in the legislature have resulted in. You can see that the priority one, which would be bills that literally require us to do a new program, change some of our current programs. We've only had one enacted. That was House Bill 3140, which removed the 3-year consulting cap. We have 2 that are Ways and Means, and excuse me, none of them have been referred to the subcommittees yet. And then we do have one that is awaiting really a Senate vote right now. For priority 2, which would be any of those benefit bills, such as the infertility bill that would require total infertility coverage. We've only had 4 enacted. We've had 9 that are at the Ways and Means Committee, and 5 that have been assigned to a subcommittee. 3 are actually at Senate Rules also. The Rules Committees, both in the Senate and the House, can they can continue business basically till sine die and refer out a bill to be voted on in the chambers, or to go, if it has a price tag, to Ways and Means. We have 3 bills there, and then 4 again are waiting for a vote. So you can kind of get a sense from here that a lot of the work that's still being done now for the rest of the legislature is going to be done at Ways and Means. And then some at Rules. And then, of course, really the end and most important thing is whether they will get a vote. That's the really kind of crux of the issue there. I'm happy to talk about any specific individual bill that you might be interested in, or any questions about, kind of what's going to be happening next with the legislature, at least till the end of sine die. Ali?
Thanks, Glenn. I just wanted to add a couple things. We truly are in uncharted territory right now. I think that even folks that have spent their entire careers in the executive or legislative budget side, nobody's really quite certain of what's going to happen. I did want to mention the fact that all agency budgets are under a 3-month continuing resolution. They are still working those. Basically that means agencies could continue. They would be allotted a certain amount of funding, or in OEB's case, where we have the funds, we just need the authority to expend those funds. They would grant that authority for 3 months, and essentially it's like a lifeline. The real problem with that is for any agencies that have new programs, new positions, those would not become effective July 1st. State school fund is a big area of risk, because I believe there's like 1 payment each year, and how they do continuing resolution is they take an 8th quarter allotment and allot that to agencies. So there are several agencies with big areas of risk here. So they're hoping for a quick special session right after sine die, which they could work through those agency budgets. I'm not sure how quickly if they could do it over a day or 2 is is a lot to ask, but yeah, it's pretty messy right now over there. And I also wanted to thank Glenn. Glenn and his team, they've worked weekends, always on call, tons of hours, hundreds, thousands of bills, and even testifying, being there for OEB, and I can't say enough about the job that Glenn and his team have done. So thank you.
Thank you, Ollie. I appreciate that. It's yeah, I just want to reiterate what Ollie said. It's uncharted territory. This is the longest that we've ever seen a boycott. And, if we do go into special session, there's also the issue that under the current rules, you literally start from scratch with the bills. You have to basically go back through the whole process of going to the policy committees, going to Ways and Means, unless they change the rules. But again, this is kind of the way that it currently is, but we don't know exactly what's going to happen. And I just wanted to really give a shout out to the folks who've done an awful lot of the work, and that's Sheila Clausen, April Kelly, Sharna Freehan, and Teresa, who on the team, who have really put in a lot of hours and done a lot of work on this.
I thought Glenn was going to negotiate between Wagner and Canope a peace treaty here. Wasn't that your goal?
uh,
All right, so we're actually slated for a break. We are ahead of schedule, but I'm going to go ahead and take 10 minutes. It's 2:02, so we will be back at 2:12. Okay, everybody, it is 2:12. We are a little ahead of schedule, and so Emery isn't quite ready to talk about Centers of Excellence. So I'm going to see if we can jump ahead of the schedule and come back to that in a minute. Tom, are you able to talk about COW update?
Yes. Sorry about
Okay.
that. I was on mute. Yeah.
No worries.
Okay. So what I have, we ended up having presentations from our dental providers. Kaiser Permanente and Willamette Dental were tasked with coming up with goals for the coming plan year. We have been working on agreeing to dental clinical performance measures for some time. The pandemic put a hole in that, and now we finally have the groups to have come up with a plan. What you see on this, and I apologize, it's a lot of data on this slide, but basically it shows what Kaiser Permanente Dental and what Willamette Dental Group is currently doing in regards to meeting 4 different types of measures. The first 2 are preventive services for adults, one with moderate risk and then high risk. The third one is preventive services for children, 1 to 18. And then the last one is oral evaluation for adults with diabetes. Now, the complexity of the last one is that the dental plan has to know that the individual has diabetes, and the Kaiser Permanente system allows for them to identify people of both Kaiser Dental and Kaiser Medical, and for those they're able then to, with relative strong assurity, be able to identify that individual. That's less true for Willamette Dental. It's also less true for MODA. And when we get to Delta Dental, we'll talk more about that. But the importance is that you see, and then you see parallel what the OEB, where it says 2022 MY, that stands for measurement year, OEB percentage, and then the same thing for PEB. And when you go out to the right, where it says under baseline CL percentage, that is their recommendation for what the target should be. Now, if you look at the targets, you'll see they are lower than their current performance. And we had some conversation about that. The first, at least for the first year, the agreement was that no fees were at risk. So in a way, what the target is not particularly meaningful, except and we had a pretty significant conversation of saying it's going to be, targets have to be aimed at improving, not at staying still or just, there has to be a hurdle. There has for improvement, and I think the dental plans heard it. So this is the agreement in regards to the targets, and when you look, you'll see Delta Dental in a bit, and you'll see their numbers for preventative services for adults different in that they're not divided out by moderate and high risk. Both Willamette Dental Group and Kaiser Permanente Dental risk stratify essentially everyone that they see, and they have different goals in terms of frequency of visits for people who are at low risk, moderate risk, and high risk. Now, sadly, what you'll see is under current performance, there's a higher percentage of people in moderate risk getting services than those are at high risk, despite both of the plans working very hard trying to get those people in. And it potentially speaks to the reason that people were at high risk was that they were dental adverse, or they didn't have the dental hygiene practices that allowed them to maintain better, lower risk. So again, that's a complex things that you all don't need to hear about, but that is we're looking at and working on. So this what we're going to be having is a separate type of targets for the two managed dental programs, Kaiser Permanente and Willamette Dental, than what we're going to be having with Delta. And it just has to do with the structure of their delivery model. Remember, there are no national targets or measures for us to be able to work with here. This is all being put together on the fly. And we are in Oregon, the CCO process has actually moved us farther along than a lot of other states have. So we're kind of working off of that. So I think I'm just so the next issue has to do with the next one was Delta Dental. We heard from them, and they talked about their and I'm trying to remember. I didn't have Rose get a slide for them, but basically their current performance for preventive services for adults is in the mid 60s. Their preventive services for children is in the high 70s, and oral evaluation of adults with diabetes was in the low 60s. The complexity for the numbers for the oral evaluations for adults with diabetes is they had to have both dental and medical with MODA/Delta Dental. And they have proposed targets for the next plan year that are also slightly lower than their current performance. And again, we raised the issue of Kirsten and the Mercer staff are going to go back over the next week or so and work with the plans to see whether or not we can actually come up with not something that is status quo or less, but actually works for improvement. And so as a board, you may be hearing more about this in September. The important thing is that it's not something where they have fees at risk for this first year. So I don't think that's something that we have to be terribly concerned about. But the good news is, the groundbreaking news is that we are on the path for having performance guarantees for the clinical components of our dental program. And I want to thank the dental plans for the work that they did. I want to acknowledge the collaboration that Kaiser Permanente and Willamette Dental did to work together to come up with, agree on how they're going to measure things. CL members, any other comment you wanted to add to the dental part? Then otherwise I'll move on to the planning for next year. Okay, without that, the last half of our meeting was spent plotting out the how we're going to work over the next 6 months. And CL wants to, by December or January, present to the board recommendations that have been vetted, well thought out, researched, that will deal with some of the things that you heard about this late winter, early spring. We're going to address the issue of doula coverage. We're going to look at weight loss, cardiometabolic disease / syndrome, where obesity and diabetes come together and increase a whole slew of risks around cardiovascular disease, cancer, and arthritis. And so we're going to be looking at our wellness programs, and we'll have an evaluation of Weight Watchers, whether or not we think that it's wise to continue with that. We're going to be looking at this class of drugs that you don't need to, the names that you hear on the television are things like Ozempic and Mounjaro, I think that's it. There's several others that are now being used for weight loss. So these are the and then we'll look at any type of changes that the plans are going to be recommending, and we're going to be having all of that in place by again the end of this year. It's going to involve work over the summer with work groups. We have CIAL board members assigned to each of the work groups. PEB has put board members on each, also on those work groups. So we're looking at a joint OEB-PEB effort here. And it's going to be a busy and exciting summer to then start putting together, and we'll start updating the rest of the board when we start getting some of those reports in September. We'll work in November and December also. So that's the highlights of our meeting, and should be pretty exciting. Any comments or additions from CIAL members? We have a 1 to 2 PEB members now attending our CIAL meetings in the morning. It's pretty exciting. That's it, JJ.
Awesome. Hey, thanks, Tom. That's great. I appreciate all the work on that. It's detailed.
It's fun.
So we're going to go to the fall meeting preview, and then we'll go back up to Centers of Excellence. So, Kristen?
That's great. Thanks, JJ. This will be pretty quick, everybody. Hello and good afternoon. We just wanted to take the opportunity, since this is our last OEB board meeting before we go into summer break, to set the stage for the fall so you all knew what you were coming back to. For the first meeting in September, we're going to set the stage and tone for the upcoming year by just very briefly highlighting the work that we all accomplished, what will at that point be last year, and where we left off. We'll get an update from the CIAL committee on all of the excellent cutting edge work that they're going to do over the summer around GLP-1 anti-obesity treatment and doula coverage. And then we'll preview together the agenda for the upcoming plan year, specifically in terms of how it's going to help you all as the OEB board achieve your goals. And then we really start jumping into the heart of the year's work in October. We're hoping at this point to have October be an all-day in-person retreat, and we have a couple of really exciting agenda items scheduled for that meeting. We're going to do a deep dive into OEB's clinical data, and this will allow you as the OEB board to look at the medical, dental, pharmacy, and vision data and understand where are some high impact opportunities for OEB, where we could focus the CIAL committee to do its work for the next 2024-25 renewal. We'll also be looking at OEB's benefits relative to the market with some benchmarking to identify if there are any areas there that we want to make changes. And then, as it came up during the call earlier this afternoon, we can revisit OEB's reserves and have a discussion around investments too. And then we also wanted to help the board revisit our goals, and they've been outstanding goals that we set last December in the retreat, and just collectively either recommit to the current goals, or if we want to refresh any of them in advance of the 2024 plan year, we can. November and December, the exact agenda items are TBD at this point. We'll see what the needs of the board are as we get closer to that time, but we do have a couple of themes. First and foremost, we're going to be gearing up for the 2024-25 plan year for OEB and focusing in on where we're going to drive the renewal strategy. We also, just in terms of how we set and build these agendas, we really heard both in the CIAO committee and also in the board meetings as well, that there's a preference, and it makes sense, to have agendas that really facilitate collaboration between all of the different people on these meetings, as opposed to the more traditional format where we all just sit and listen to reports being given. So we're going to take great care with our agenda items and looking for opportunities to collaborate and have discussion as much as we can. And then, also running throughout every month's agenda is this theme of achieving OEB's goals, and always making sure that our agenda items are driving towards meeting 3.4%, educating our members and other people we come in contact with, shifting left on our chronic conditions, catching and treating them early, and then driving towards quality and efficiency while keeping the member first. So these have been our guiding principles so far, and we'll keep those in mind as we go throughout the next year. So that's just a quick update. And from the Mercer perspective, we hope everybody has a wonderful summer, and we look forward to working with the different CIAO work groups over this summer. So JJ, I'll hand it back to you.
Thanks, Kristen. I appreciate that. We got a lot of good work ahead of us, so it'll be fun. One quick thing I gotta. Okay, so we're going to go back to Centers of Excellence. So Jeff and Emery, I turn it over to you.
Great, thank you. Well, we thought it was time for
actually, 1 second. We got a hand raised from Susan.
JJ,
Go ahead,
I was
Susan.
just wondering, yeah, thank you very much. I was just wondering if we had a date for that October in-person all-day retreat. If we could get that as soon as possible, that would be really great.
I believe it'll just be our regularly scheduled meeting.
Oh,
so, yeah.
Okay.
So instead
Great,
of it
thank
being
you.
over Teams, it'll be in person.
Thanks.
All right, thank you. Go ahead, Jeff and Emery.
Okay, before I turn it over to Emery, just wanted a couple of preface comments. We're in our 4th year, actually, of addressing the potential of a Centers of Excellence program. It was back then that in reviewing our claims and the areas that we might expend energy on, that musculoskeletal issues were raised as an opportunity. And that was based on a wide range of cost and a variation of outcomes. So we thought that was an opportunity not only to increase the standard of care for our members, but also to realize some passive savings in avoiding recidivism and complications. So our consultants at the time did a survey of Center of Excellence vendors, and effectively what they reported back was there were no vendors with a Center of Excellence located in Oregon, so they would be providing opportunities to go out of state. It seemed that that just didn't fit OEB's culture, and given the diversity and geographic layout of OEB members, we determined that it would be desirable to develop a state-based program. So it was passed over to the Innovation Work Group, and they were charged with the project. And we have started on this journey only to run into some basic challenges, meaning COVID came, changing consultants came, post-COVID, we've run into capacity limitations of physicians and facilities. And also, as we studied the data, we've determined that to have confidence in what we were recommending to our members, we needed to expand the data that was being analyzed for us to have assurance that we were making the best recommendations possible. So Emery Chen is the actuary who has been crunching the numbers and guiding us through this process. And we have developed a comprehensive, this is where we are report for your review today. Emery, go ahead.
Thank you, Jeff. Yeah, so for those, some of you actually have worked with me in terms of the IWG, and but I'm Emery Chen, actuary. I am on PEB and IWG, and I'm happy to speak with you here today to give you an update on the Centers of Excellence and where we are headed on that. So the agenda here, we're going to provide a little bit of information on, I guess, a little bit of the background and why a Center of Excellence. Just a brief touch of the history, as well as where we are and where we're headed, and then some more information about the COE, including giving a preview of the types of approaches that we're trying to do, at least in the immediate term, for trying to really improve the member care, like as Kirsten had mentioned, moving left, trying to potentially avoid those surgeries that are unnecessary, and to provide the best quality care for the OEB members in this case. And so hopefully the COE can try to achieve that, and we're here to show you how we intend to achieve that goal. So moving on to the next slide. One more slide. Thank you. So, this is just a little bit of the history on why considering a COE. Back when IWG was started, we took a look at the different types of claims that were impacting OEB and PEB members. And for OEB, maternity, cancer, and musculoskeletal were some of the top ones. And we were trying to figure out ways to, approach quality and cost for those types of services. And for musculoskeletal, COEs are a big thing, and there were definitely a lot of services. And what we also found was, that the care potentially is unnecessary, as you see down there in the bullet, that some care might, it's on the additional cost tier list, right? Because it's an optional surgery, and as much as 30%, as many as 30% of your surgeries may be unnecessary. So why have such an invasive procedure if it's not absolutely necessary? And also the complication rate, 3 to 5%, of surgery. So that's a significant number of members who have issues, readmissions or other complications. Maybe they don't return to function. Their quality is not actually improved. It may be worse as a result. So, try to find out ways to prevent that from happening, to get the best quality care for your members. And, the best quality, you can avoid readmissions and save costs in that case. So what we did was to focus on the musculoskeletal, in particular, knees and hips. And so moving on to the next slide. So with the COE, focusing on that knees and hips, although we are also looking at back and spine in terms of trying to get the data for that, we are trying to, shift left here, prioritize early interventions for surgical alternatives. And we have a slide or two on this towards the back that we can go over. But, it's like, which patients are appropriate for surgery, and are you appropriate for it in terms of not only in terms of your knee and hip function, or potentially your health conditions? Is there certain things in your health condition that might make you more susceptible to a complication? But we also want to find out, there are quality differences across, providers. There are some that have more complications, more readmissions, and we want to know which facilities and providers have those issues, and we want to find out which are the best quality, and we want to get the data to show that and to help direct the member so they can find out, which providers are best quality, so you can put yourself in the best possible position if you're having those surgeries and improving those outcomes. So that's really the intent of a COE. Are there any questions before we move on? Comments? Okay, thanks. Next slide. So a little bit on the history. So as Jeff went through some of this in terms of the history and going back. So where we want to focus on is last year we started looking at some data. We got some data from a couple different sources, including Clarify, which is a vendor that Mercer has worked with and has some quality metrics. And we also got some APAC data as well from a vendor. And APAC data, for those who may not be completely familiar with it, it's the All Pairs, All Claims database for Oregon. And so this essentially has the vast majority of all of the claims in Oregon. And so what you can do is take a look at the number of procedures, the providers, the different types of, whether it's commercial, Medicaid, Medicare, and take a look at the claims in terms of which providers have the best results for knee surgeries, which have the worst, try to take a look at that. And when we looked at the information, what we found was that, we want to make sure, it was telling the same story in some cases, but not in all cases. And so what we wanted to do was to focus on data that we can trust, that everyone can trust, and run that information and get as much as we can. And so what we did was to say that, APAC has basically all the claims in Oregon, and we're going to get more years of APAC data and use that to try to see which facilities are the best. And so that's what we're currently working on in terms of running that data and getting it. And that's part of what we're going to use for the education of the members. While this is going on, we wanted to also talk with all of the, the stakeholders or, the interested parties, which, includes, OEB, the board, which also includes OEB members, providers, and the plants, and as well as other people. We just want to make sure that everyone's on board, that the numbers that we have, the quality is trustworthy, as well as, the approach of what we're trying to do. In terms of trying to, educate the member, make sure, identify the facilities and potentially plan design and other things moving on forward. So what we did was to kind of start up those conversations. And we had a conversation in essentially March, April, which is on the next slide. Next slide, please. Thanks. So, and we got some feedback from all these interested parties. So one, we talked with the carriers and we heard some potential roadblocks to implementing a COE with plan design. So in terms of contracting, contracting with facilities, they said was going to be difficult. And we had initially taken a look at potentially, tiering facilities and maybe having plan design around that. So to really steer members to essentially what we would say would be the higher quality providers. But there were concerns about the contracting, as well as making sure we had the right data, as well as potential limited provider capacity. As Jeff mentioned with COVID, healthcare changed, and it's still ramping up. And in some cases, there was a potential delay in care, and there's big influx, and not all providers are able to essentially provide services at this at the levels, they're full essentially. If you wanted to go get surgery, you would have wait times, delays. And so, that having that issue out there, would greatly impact the member. If we did have a plan design, which essentially gave you, either benefits to go to a high quality provider who might not have capacity, or, potentially punish you for going to a different type of provider. So that was a major concern. Another concern that we heard were in terms of the travel, travel is, for members, especially OEB, which could be some in the rural areas, travel is going to be an issue, whether you have to go into the metro area, the Willamette area, or other places out of state, potentially, there's potentially burdens on those for travel, as well as dissatisfaction if we say a provider in your area may not be as good, and that you would essentially have to pay more to go see that provider. So based on this feedback, what we are doing is we're actually going to kind of take a step back from the plan design and focus more on education and member and provider changes in terms of trying to identify and to make sure that the members are in the best possible position to have these types of surgeries if they want to go have these surgeries, so that not only are they qualified to, the member meets those health requirements to have the surgery, but that they know which providers are potentially the best and to make that informed decision on which provider to go to. So that's where we're going forward. But we also are going to continue working on potentially, taking a look at plan design and, potentially other things moving forward. We're not completely giving up on that. It's just going to be pushed back a year or so. Any questions or comments?
One thing just for me real quick is I just think it's important to let everyone know that we had concerns about, the accuracy of what we were looking at, but also we wanted to reiterate the purpose. And people, when they hear Center of Excellence, they just assume, well, we're just here to give you low ball services or whatever. But our focus was reducing the rate of complications, because in doing so that reduces cost, but it ends up a better member experience. And we're looking at likely 40 to 50% reduction in complication rates at a minimum, and that's huge when it comes to cost, because as we all know, the handful of cases that end up having to be redone are where a lot of that money comes in.
Thanks, JJ. Moving on. So as mentioned, where do we go now? So we aren't focusing on plan design. We are going to run the data for quality, and we're going to try to focus on member communication, as well as talking, educating on high quality providers and talking to the providers and other, and the plans about the requirements and what we think, a center of excellence in terms of providing quality should achieve. And so trying to lay that groundwork for really implementing a solid COE in the future. So we're getting the APAC data, and we're going to do some outreach and, offer that information as we move on through the next year. Okay. Next slide. So there's next couple slides have a couple points of data just so you can see on the number of surgeries for the OEB, and then additionally, in this case, this slide, PEB members. So for the knees and hips, you can take a look at the surgeries, current, prior, and prior 2 years. So essentially, the current year would be 12 months on a calendar year basis for OEB. So taking a look there on the top left, there were 34 inpatient surgeries and 189 outpatient. As you take a look, that's less than what were done the 12 months prior and the 12 months prior to that. But one other thing that you can see is there has been a shift in terms of surgeries from inpatient to outpatient. So a lot more surgeries are being done on an outpatient basis. In terms of the regions, there's 11 PEB in total, but actually if we move on to the next slide, this shows OEB in particular, and as well as where the member is and where they have the surgeries. So what you can take a look at, going from left to right at the top, you can see where the member's located. So Central Oregon, which is where I'm at, I'm in Bend. And then you have the coast, which is on the west side of the state. You have the metro area, the Portland area, and then you have the northeast region. And we also break out the southeast region as well as southern, which is kind of in the Klamath, Grants Pass area, and then the Willamette Valley, which is down the I-5 corridor from from Salem down south to Eugene, and then out of state. So what you can see are the member regions over there, and then from top to bottom, in the same order, you can see the facilities where those members had the surgeries. So if you want to take the diagonal from left to right that are in the boxes, those are the members who are having the surgeries in the same place that they reside. And you can see if you go to the bottom right, that's about 74% of the members in total. But that means 3/4 of the members are staying in the same region that they're having that they live in to have the surgery, but 25% do travel. And where are those 25% coming from? If you take a look at the very bottom, there's 3 areas to focus on. So the second column, which is the coast, 31% of the members there are having surgery as a facility on the coast. That means 69% are traveling out of that area. They do travel to the metro area, the Willamette Valley area, as well as southern. So they do travel basically up and down the I-5 corridor, as well as potentially going out of state into most likely Washington in this case. The Northeast region also has 50% of the members who go out of their region for traveling for the surgeries. And those are out of state, so whether it's Washington or Idaho for the most part. But there are people who do travel either to the Bend area, Central Oregon, or even Portland, or go down southeast. So there is some traveling going on there. And then the southeast, essentially, all of those people do travel. While their populations are not as big, there are definitely members who have to travel or want to travel to get their surgeries. So, that's part of what we're trying to do with the COE is to make sure that the members know that the facilities that they're going to, potentially, if they're going to travel, is a high quality facility. Because if they're unfortunately going to have a complication, those treatments may not be found in their area, and they would have to go again, out of area to have that surgery. And so we're trying to avoid that, member impact on members. Jeff.
Yeah, just a point that using the All Payers, All Claims database, which is Oregon centric, is that where we're looking at the Northeast and we see 17 out of state, that's most likely largely Idaho. And there are opportunities for us to consider a hospital or two along the border. So we're reaching out and investigating that as well. But early concerns about travel seem to be lessened when we look at this. That yes, some people might have some resistance to going out of their particular area, but we're not really fighting uphill that much because quite a few need to travel because of what facilities are available to them in their area.
Yeah, we will have some. Yeah, so we're trying to meld what data's in the APAC database with another source for those border facilities. So all along the Washington border. I mean, there are the wall Tri-Cities, Vancouver area, as well as up and down Idaho, because there are those hospitals that members are going to, and we just want to make sure those hospitals are good. In some cases maybe they're more expensive, but we also want to make sure that they're good and direct people to the best place possible for them. And maybe that does involve traveling, but we just want to make sure members are educated in this case. Any other questions or comments? Okay, moving on. One thing that we wanted to bring to you was really, we set up some IWG values, because when we're doing a project like this with the COE, there's lots of things, and we just want to make sure it's centered upon essentially the values of the OEB and PEB boards, as well as the IWG, and just trying to, achieve the best possible care. And so, the triple aim is a huge, is a core value, and the IWG is, along with the boards, you're trying to achieve, achieve projects, achieve solutions that do achieve the triple aim in this case. Some of this other topics, we're trying to help the members. We're trying to intervene as early as possible to shift stuff left again on the scale prior to having a surgery. Education is a big thing. The list of principles is pretty long. It's on the next slide as well. Moving, thank you. So, allowing that member to make that informed decision, that's a huge thing. That's essentially what we're trying to achieve, at least in the short term with the COE. And we're trying to avoid that unnecessary care, as JJ was talking about, of avoiding readmissions, complications, and just educating the members. So that's really the goals of this COE and the goals of the IWG in particular. So, as we talk about plan designs, as we talk about what we're trying to look at, data and design and education and everything, these values, which principles, which, tie in, I think, pretty nicely with the values as well. That is our, our goal, our North Star. Moving on to the next slide. Project plan. So some of this we talked about earlier. So phase one, we are doing doing the APAC data and doing information, trying to share that. And then phase 2, we are hopefully doing more, taking a look into harder plan design, incentives, disincentives if possible, as well as potential contract requirements and maybe cost adherence to patient criteria, and making sure there's alternatives for patients who don't meet the criteria for surgery. We do have a list of criteria that we talked about with the plans, and some of that's actually in a couple slides later, but we talked about what criteria would make it most advantageous for the member to succeed in their surgery. And some members may not meet those criteria. So what can you do to meet those criteria? Or if you can't meet those, criteria, what other options are there for you? So that's part of what we're going to be developing in full over the next couple of years. Moving on. In terms of education and steerage, so we've talked a little bit about some of the people, interested parties. 3 of the main ones are here: the carriers, providers, as well as OEB and PEB in terms of the boards and the members. These are the education, the communication approaches that we want to have with each of those interested parties. So for carriers, talking about making sure the members essentially identifying members, and if a member asks about benefits for knee surgeries, getting pre-auth, getting that early intervention to make sure that they meet the criteria, that they get the information about what's a high quality provider, and having the carriers provide that information to the member, and to also help them with the prior auth and making sure things are smooth in this case. In a full-blown COE, I think we may want to have kind of a advocacy concierge type solution with that, but first step is trying to get that information and helping the members as much as possible. With providers in the mill, we want to share the results to let them know, some of them might be high quality, to let them know that they're high quality and that we like that they're high quality and want to agree with them, and to potentially maybe let members know that they are high quality and they might get more patients in that case if they can keep up their quality, as well as collaborate with them on making sure they understand the rankings, and if they do fall a little bit lower in the rankings, where they might have some room for improvement, as well as education campaigns with primary care providers. Primary care providers can help steer where the members are, so that's a big part of it. Physical therapy providers, emergency room. So just trying to get, that further left on the spectrum of where the care is happening, before you get to the surgery, to the surgeon. And then there on the right, we want to talk, the members are, essentially the key focus, but, providing that information, get them the information about the quality, communicating with them however it is. There's different ways of communicating, and just try to make sure that they actually read the communications rather than delete the email or throw away recycle the flyer. But it's like, how are we going to do that? How are we going to get their attention and get them to understand? So while we want to get them that information, it's really the communication and what's the best way of communicating that information to them is kind of part of our focus for this year at the very least. Any questions on the approach for communications? Comments? Okay, moving on. So this is just a quick look at the project plan in terms of the timing. So in terms of reviewing the data and the metrics, we are kind of working on that. It's actually pushed back a little bit due to contracting issues, but we are working on that. And then we'll get that information and work on finding out what collating which providers are quality. Then we're going to do that information. It's not to January 23, it's actually January 24, but we're going to work on that communication through the second half of the year in terms of that information-based approach. Next slide. And then this is talking about the second phase 2 in terms of contracting, plan design, and travel benefits. So once we work on making sure that education phase is done and that everyone is on board, then we can maybe work into the little bit more difficult task of creating that COE, developing that COE in the future. Next slide. So talked a little bit about pathways for members who reaching them early, right, on the care spectrum. So What do we mean by that? This slide provides a little bit more detail about it. We want to say that prior to having surgery, we want to make sure that you potentially had some activity modification. It, uh, just making sure that maybe there's ways of changing what you're doing, or exercise, physical therapy, or other things that you could take that might help the situation before you go and have the surgery. In some cases, it may not work. Some cases, you may have tried that for a while. And if that's true, then you can move on to surgery. But before just saying, hey, if I feel like I hurt my knee, I want to have surgery, or my hip hurts, let's have a hip replacement. Let's try a few less invasive things before we get there. And additionally, it's not just surgery. I mean, weight loss, there's other injections, cartilage transplants, if medical necessities met. There's partial replacements. There's different options rather than the full-blown, hip or knee replacement. So they're, just making sure that the member has all of the information to get the best possible care for them, and making sure that the providers, don't go to the highest acuity solution, that they approach and try to do these lower impact things that might help, and potentially avoid that 30% of surgeries that might be unnecessary in this case. So trying to save money by, again, meeting them further left on the care spectrum. Next slide. If you are potentially meet the criteria for surgery, we do believe there are certain clinical metrics that you should meet. And we've discussed this with the plans and doctors. Tom was, part of the conversation in terms of what criteria should you meet in order to be appropriate for surgery. So there are some clinical goals on the next 2 slides. I won't go through all this, but we talk about what they are, as in terms of why they're important. And then, if you don't potentially meet those goals to start out with, we have some actions and strategies that we want to have, the surgeons or the plans or the members know about, as well as the PCPs and, the therapists, physical therapists, having them know these goals, the action strategies that might get them ready for surgery if they do, meet that criteria for surgery, or they do need that surgery. So these are some of the things that I think we want to help educate and get out there, let the members know as well. So some information here, and then on the next slide is our part 2. So, some of the other things, trying to get your BMI down, not smoking, just things that might put you at a higher risk of complications or readmissions, and avoiding those. So these are some, metrics that we want to have populated and make sure that everyone is following them, as well as giving the members ways to essentially achieve these if they do need that surgery. So it's trying to hopefully think about the total care, the holistic care of the member in terms of the knee surgery, knee hip surgery, and getting them not to just, return a function, but potentially improve function. It's like, why have the surgery if you're just going to be the same as before? We want you to be able to run, walk, do whatever that you want to do as a result of the surgery. And hopefully these things will help achieve those goals.
Hey, Emery,
yes.
It's Cindy. I just wanted to mention that all of these things are also associated with a higher risk of infection and complication. And so that's a primary goal for focusing on them, is we want to make sure that folks, we've optimized the reduction in risk for members.
Yeah, thanks. And actually, I think that's the last slide. So I will open up for any questions, comments. Okay. Well, hearing none, you can talk to your IWG members, JJ, Jeff, and Tom, as well as, Kirsten and myself. And if you have any questions or comments, and thank you for your time.
Thanks, Emery. Appreciate it. All right. So next on the agenda, we have medical plan, customer service, member experience surveys. So let's go ahead and start. Do we have Kaiser first? Yeah, Kaiser's first.
And this is Lindsay Leewergen. I'm the Vice President of Consumer Experience for Kaiser Permanente Northwest, and I will be walking us through our presentation today. So let's go ahead and hit the next slide. So this is a slide we shared last year and wanted to bring it forward again. These are the different ways in which we gather member feedback. We have a brand tracker that we use across KP, all of the regions, and we look at how are we comparing to our local competitors in the market, where are we ahead and where do we have opportunity. We also use CAP scores that come out of a variety of sources from hospital, commercial, Medicare. We have targeted surveys to understand the new member experience. We also have member feedback that we gather from medical visits. Those are both in person and virtual, and we use that feedback to, again, refine what we're doing and improve. Similarly, we have those surveys for dental as well. And one piece that, while not new, we've certainly spent a lot of focus on this year is our real-time feedback. So we all know social media is here to stay, and like many other industries, healthcare gets rated online. So we've been spending a lot of time understanding what those ratings look like, helping to respond to them. So our goal is when a member sends us feedback, we are either recognizing the staff who were complimented in that comment, or we're calling, doing outreach to do service recovery within 3 hours. So we've seen really nice improvement in care delivery, just getting the care delivery teams closer to the member by really incorporating those real-time member feedback comments into our operation. Across the board, we wanted to share what our members are telling us in 2023, and we do overall have very happy members with 97% satisfaction with in-person visits, slightly lower with 94% for video visits and 93% for phone visits. So this is just a really nice overview of, again, the variety of ways in which we gather member voice. So let's go ahead to the next slide. So we were asked to not just give you all like kind of a dog and pony show, but get more specific on some of those key areas where we've had opportunity, we've heard from our members, and what are we doing about it. So I wanted to give some very tangible examples of improvements we made, and then I'm going to pause and ask board members if there were additional areas you were hoping to hear about that I might be able to provide some details on. So areas of focus, and I don't think it'll be any surprise, access is our giant focus, as it is in many other organizations. Some real bright points for us around access. In primary care, we are in process of hiring 66 clinicians. This is more clinicians than any time in history. With those clinicians on board, and they're staggered to start in the coming months, we'll be adding 10,000 primary care appointments per month. We're also looking at specialty care, and we've added things like additional virtual care options. We've added scribes to our physicians so that they're able to provide more hands-on in-person care while someone's helping to do that charting. And those two simple changes have added 3,000 appointments per month. We're also working with each specialty on how can we improve your schedules and your templates? How can we make it easier to appoint into your schedule, make it faster? And that work is going to be adding 500 appointments per month. So we're really doing everything we can to look at our system and figure out how do we pull out the noise and make it easier and easier for members to get those appointments that they need. In urgent care, we're really working on throughput. So we've been challenged with urgent care as we don't have enough access in ambulatory care. More patients are going to urgent care. So we're doing two major things in urgent care. One, we're focusing on throughput. So from the time the member arrives at the urgent care to their care needs are met and they're able to leave, let's shorten that up. So instead of waiting a very long time to see a clinician, our goal is that you're seeing a clinician within 20 minutes of arrival and we're getting that care met. That work, we've seen an overall 10% reduction in time in urgent care, which creates more space for us to see more patients in urgent care. The other thing that we're doing in partnership with primary care is we have a goal of 80% of patients that need to be seen for an urgent need will be seen within 2 days in primary care. So we can pull some of that pressure off urgent care by offering members another option to have a scheduled appointment in primary care in a very timely way. So trying to balance those needs. Mental health, this is another area we hear a lot about, not only in terms of access, but we also have to think about things like appropriateness of fit. goodness of fit with the mental health provider. So we've spent a lot of time really looking at our screening. So how you come in and we get you mapped to the right mental health provider that's going to meet that need. We've also hardwired our 24/7 options. So when there's urgent emergent situation in mental health, we have a variety of options available. And now we're really taking a look at how do we expand our provider network so there are more options for every member to make sure that they have the perfect fit of mental health provider for their needs. So really spending a lot of time in that space and have seen really nice improvement overall. The other piece, and again, tying with primary care, and then I will go to the hand, is we're embedding our behaviorists in primary care. And this is a concerted effort to look holistically at member care from both physical and mental. And that connection between the medical primary care team and the behaviorist we've seen has made a marked improvement by bringing those two care teams together in a really practical way. And please, I see a hand.
Yeah, just real quick, those increases in primary care visits, is that Oregon specific or national numbers?
Those are specific to our region, so Southwest Washington and Oregon.
Perfect, thank you.
Yeah. The other piece I will add, I didn't mention this on the slide, is around our virtual care options. So we have a variety of virtual care options, but two I want to call out. One is our virtual urgent care, which we call Get Care Now. At any time, you can go onto the app and get real time within 2 hours, a face-to-face interaction with a physician. And we're now doing 7,500 virtual urgent care appointments, and the satisfaction with those visits is very high. We're also continuing to expand our e-visit options, which allows members to have a self-service kind of choose your own adventure. And there's a provider on the back end that's overseeing that care, but you can get to whatever that care disposition is that's clinically appropriate, overseen by a doctor. And that also, we're doing 8,000 of those per month. So really just trying to get as many different options that are going to meet the member need and that are also convenient and easy to use. And then finally, on contacting Kaiser Permanente, we are now very proud to say if you're calling the call center, 80% of the time you will talk with a call center agent within 30 seconds. And in our message turnaround time, we have reduced that turnaround time from up to 16 hours down to 8 hours, with the vast majority of messages responded to within 2 hours. So we're really, again, trying to make sure members need something. They're not waiting until the end of the day, the next day, enjoying dinner with their family where they're still not sure what the next step in their care looks like. Were there any areas of care delivery you were hoping I would talk about that I haven't touched on?
Hi,
Okay.
Chris, I have a question.
Yeah.
Yeah, I just I'm curious about your stats because a lot of the educators who are members of Kaiser, I constantly hear that the wait to see their primary care is long, and you provided data saying that the people or patients are seeing their provider within the next 48 hours. There's appointments available, but maybe my interpretation is, yeah, there's a primary care available, but not the primary care that they have selected as their main provider. I was wondering what Kaiser's doing on the primary care perspective, on the burnout of medical staff. And, you know, we have to recognize that you do have a good system, but we have a system that is lacking of the proper staffing to be helpful for those members. And also to the previous overall the conversation about the travel for members, I'm just really concerned that we haven't addressed that fully as a board, but that's a different topic. But anyway, thank you.
Yeah, so I'm not sure if I understand the travel piece, but let me speak to the first one. So you're right. Paneling capacities. So before COVID and even through COVID, we've had I would say, an imbalance in our care delivery system where we've had different thoughts, as other healthcare companies have, of how important is the relationship between the member and their primary care physician. Do members just want to see any primary care physician when they have a need? And to my statement about you have an urgent need, you'll see a doctor within 2 days, that is with any clinician. When it's specific to your clinician, it does take longer. And what we've realized through these past several years is members do have relationships with their primary care physicians. It's an incredibly valuable and frankly, at times underappreciated relationship that we need to spend a lot of time on. That's why you'll see noted on this slide, we're adding 66 primary care clinicians. They will be paneling clinicians. So they will have their members that'll be paneled to them. And those members, when they call in, we will direct all of our scheduling appointing systems to get the member with their primary care clinician. If that's not possible, the primary clinician simply has nothing available, then we still want to get you seen with a clinician, but we're reorienting all of our systems back to that relationship with the primary care physician. The other comment made about staff, we're also adding 64 support staff members that will partner with these new clinicians. So we really are working to right size our staffing to appropriate workloads because we cannot continue to burn out our healthcare teams. We need to make sure they're appropriately sized so we can provide optimal care.
Well, thank you for the clarification. Maybe your intent was not the way it was received or was conveyed that, oh, no, we have no issues with our primary clinicians, or there's no issues on members having them keep it the same primary physician. So I'm glad that you were able to expand that we do have a problem within Kaiser, and that's the role of this board to pressure Kaiser and MODA to provide those services and to let the problems be known and not just cover with facts that, hey, within 2 days, yes, but members want to see the primary care they develop a relationship.
You know, it is agreed, and I would press, and then, oh, I apologize, Dr. Brockman, I'll send it to you in a second. Oh, go ahead, you'd appreciate.
Yeah, because what I was going to say that I appreciate that Kaiser's adding more primary care physicians and expanding the services because it does impact your biggest client, which is educators and public sector employees. So I'm not attacking it. I'm just saying that I am thankful for the clarification because it did came across that we had no issues in the system when Claire didn't do.
Absolutely. And I, again, like I mentioned, I think we're learning more and more that power of that relationship is so critical. And again, need to orient our staffing and systems to that. And Dr. Bachman, I think you were going to jump in.
Yeah, I think I was just agreeing with the way you put that. I would say we are designing our systems to reinforce primary care. Our shortages in primary care, we're lucky right now that we're seeing lower rates of turnover and attrition than we did over the last couple of years. And we're having more success in hiring, yet we are still not fully staffed to achieve the access goals that we want. Yet, it's a community problem, it's a Willamette Valley problem, it's a rural Oregon problem, it's a national problem. So we are committed to it. We think we can thread that needle and hire and reduce attrition and get people paneled that want to be paneled and seeing their clinicians in a timely manner. Recognizing some people do great with the video visit with anybody, video urgency care, with the Get Care Now, e-visit, other ways of getting care, or via email. So lots of different ways of getting care, but we are committed to this as sort of designing our system really more so than we were a few years ago to strengthen and bolster primary care.
Thank you, Doctor.
All right, let's go ahead to the next slide. All right, so this is our last slide, and we really wanted to spend a little time talking about how are additional ways in which we gather member feedback. What are we doing for marginalized populations? What are we doing with information we've gathered from the Real D survey? So that's the intent of this slide. We did want to share that we do have a variety of patient advisory councils. So you can see those listed on the left side of the slide. And we use those councils to bring targeted strategic questions in based on the care experience of members in these different settings that then gives members a direct voice into the strategic problem solving space with us. So again, we have a variety of members. We have over 100 patient advisors that come in as needed to provide support in those areas. We're continuing to focus on care experience variation by race and ethnicity. And a big step forward in this space is our new Center for Black Health and Wellness Center, which will be opening up at our Interstate campus in early 2024. The intent of this work is to really make sure we're providing optimal care for our Black members and communities in a way that is as culturally sensitive and responsive as possible. So this is a new center we're standing up soon. It's really one of many steps we'll continue to take to close that variation by race and ethnicity. And then we also wanted to share work we're doing with our patients with disabilities. We continue to look at different ways in which we can expand care options for this population. So we continue to offer a variety of interpretation services, which we're constantly growing. We have different options for audio impaired, like transcription services. We have audio options for insurance forms, like billing forms, things like that. We also, for visually impaired, we have large print braille options, and then you can see a variety of options that we do for those disabled members. So again, just hoping to share some different ways in which we're continuing to innovate for all of our members and their needs. So that's what I have. Any questions? Anything else we can expand upon?
I don't hear any, but thank you so much. I really appreciate your presentation today. That's exactly what I was looking for. I'm just one board member, but that sort of specific is what I'm hoping for with these kind of talks. So thank you so much. All right,
Thank you all.
Next we have Moda.
Hello, good afternoon, everybody. My name is Erica Hedberg. I'm Director of Government Programs for Moda. And I am going to be talking about some results from a customer service survey that we fielded, as well as ways we've responded to some member and entity feedback. So next slide. And when we think about the member experience for OEBB members, we're always looking at it through the lens of Moda 360. And just for a little recap on Moda 360 and how we really deliver that member experience, there's really 4 different levels to it. The first level is all relevant member data. And this is really talking about how we are collecting more data on members, and we're not seeing the member as just a diagnosis on a claim, but we're also gathering additional data around health context, social determinants of health data. And we take all of that data and we bring it together, and we use that to then recommend and create point solutions. So as you are probably aware, we've been bringing on a lot of new programs lately, and these programs are great for members because they really are targeted at certain chronic conditions and can really help members manage their health. But there's a lot out there, and we continue to keep bringing on more, and that can be very overwhelming for members. And so we use all of the data that we have about a member to actually propose the programs that we think will work best for that member specifically. And I'll give an example of that here in a few slides. And then the third layer is human connection. And this is really speaking to our health navigators. The health navigators are really there to help members navigate the sometimes complex healthcare system and also help them with that next best action. So our navigators have a special technology platform that they use that gives them a lot more information about our members. So it tells them any care gaps that they have. It also gives them those programs that we think would really benefit that member. And it also gives them just an overview of where that member's at. If they've had recent ED visits and prescription refills, adherence levels, a lot of information so that the navigators can not only help them with complex situations, but also can help them with other next best steps. And then that top layer is delivering healthcare with context. So that's really bringing all of those layers together and personalizing that healthcare experience for each member. All right, so next slide, Rose. Thanks. All right, so now I'm going to talk about a survey that we do of members after they've engaged with the health navigator. So when they reach out to our health navigators, we ask them if they'd like to take a survey afterwards. So members can opt into that survey. And then after they interact with their navigator, then that's when they give their response. So next slide, Rose. And so for last year, OEBB members reported 95% were overall satisfied with the health navigator, and 98% were satisfied with the health navigator's knowledge. So we've been getting a lot of really great feedback from our members. If you go to the next slide, Rose. This is just a handful of recent feedback that we've gotten, and I'm not going to read it out to you, but I put it here in the slide so you guys can go back and read it. But this comes from members who took the survey and then also just other members. A lot of times when members will say, no, they don't want to take the survey, but then after they engage with the health navigator, they still want to provide feedback. So they'll end up emailing it to us. So this is just an example of some of the feedback that we're getting. And my team has also been out meeting with school or with entities recently and the last couple of months. And we've been getting a lot of really great feedback from the entities as well on the health navigators. Next slide. Right, and then we are seeking to get some additional input from members on how we can better meet their needs. So we have two things coming up in 2023. The first thing is we're going to be doing a Net Promoter Score. So that's a survey that's really looking to get at the customer loyalty and satisfaction measurement. You might have heard the Net Promoter Score in PS used for other vendors and different companies. So that's what we'll be doing. And we'll be fielding that during this year in 2023. And then we're also going to be doing focus groups. And these focus groups are going to be mostly focused on our new member dashboard and the way we digitally engage with our members. And so we will be doing that in 2023 as well. And we've already started this work. So we'll have more to report next year as we are getting additional input from members. All right, next slide, Rose. Great. And so now I'm going to go into just how we've taken the feedback that we've gotten from both our members and our entities and how we've applied that. And one way we've done that is through that new member dashboard. And this launched in January of 2023. And it's really just an enhanced, easy to use layout that's personalized to each member. So next slide, Rose. And there are a lot of different things in this dashboard, but I'm going to focus today on the programs because this is some of the feedback that we've been getting. And as I mentioned just a minute ago, between MODA and OEB, we have so many different programs that members can engage in. We have programs that are invite-only programs. We have programs that OEB offers, programs that we offer. And that can be really overwhelming for members because we're trying to communicate about all these programs to them. So they're getting letters, they're getting emails. On our old dashboard, they could go in and we had a page in there with just a bunch of links for more information on these programs. There's links on our website, links on OEB's website. So there's a lot of different places that members can go, but it's really difficult to understand what those programs are and if they're a good fit for you. And so what we've done is we've taken all of that information that we've been gathering about that member and we run it through what we call a personalization engine. And then that picks the top 3 programs that we think are the best fit for the member that they could benefit from the most. And so this is what it looks like in the member dashboard when someone has clicked on the MODA 360 programs. So this member here is a type 1 diabetic, and there are 3 different programs that we've recommended for them. The first one is the Comprehensive Coordinated Care or C3 program. And this is an invite-only program. It waives the cost sharing for PCP visits as well as mental health visits for members, and it also assigns them a dedicated advocate. So this is an invite-only program. We probably sent this member a letter maybe a year ago, and they didn't see it, they didn't respond, maybe they were busy, but it's not a program that they're going to see, advertised on our website because it's only available for certain members. So here in the dashboard, we've identified it as the top program that we think would be the best, that would benefit this member the most. We also have given Cirrus MD, and then also case management. And case management is also an invite-only program. So this member, someone who has chronic disease that we're really trying to get engaged in these very specific programs. But in addition to the top 3 programs, we want to make it easy for members to be able to find any program that they're looking for. So members can click here on View All Programs. There are other ways to get there, but this is the way off this page. So Rose, if you go to the next slide. Thanks. When members click there will be a list of all of our programs, and they're all in these little boxes here. So you can get a short description of what the program is, and then you can search by categories. So here I've searched by mental health, behavioral health, and then all of our behavioral health programs will show up here. So here you're going to see Spring Health, you're going to see the behavioral health champions, and then you'll see this addiction Care with Hazelton, Betty Ford. These are all new programs with the Behavioral Health 360. So if a member wanted to learn more about Spring Health and how to access those providers, they'd click here, and then Rose, next slide. And then it's going to give a description of the program. And then it's always going to have like a call to action. So a way that a member can engage with that program. Here, Spring Health, it has the learn more and enroll. So a member can click on that and it's going to take them just directly to the Spring Health page where they can enroll and start using the program. Other programs like C3, which is an internal program, it'll have an email address and a phone number that the member can reach out, but it just makes it easier for the members to engage in the programs that are right for them. Any questions about that before I go on? Great. Next slide, Rose. And really quick touch on this. We're also starting to apply the same approach to our outreaches because, again, members have been saying that they're getting a lot of information. They get emails and letters from all sorts of different people around their healthcare. So we've developed a calendar for OEB where we only reach out about certain programs during certain times of the year. And then we've also started applying that personalization engine to those outreaches so that we're outreaching to members about the programs that we think would be best for them so that it's not just a bunch of noise coming to them. Next slide, Rose. Right, and then lastly, I just wanted to share how we're getting some of this additional data from members. So in the new member console, we have a few different forms that members can fill out. One of them is the accountable healthcare survey, and that's a survey, this one up here in the right corner, that really asks a lot of different questions that's really looking to get at if members are experiencing any social determinants of health. We also have the Real D survey in there, which asks for race and ethnicity, and then the SOGI survey in there, which is sexual orientation and gender identity. And what we do with that data is when members complete that, it goes into our system and then it gets put into our health context and our personalization engine so that it's used to help us identify what programs would be best for that member. And in addition, for example, if a member filled out the SOGI form and said that they wanted to be identified as they, them, their, that shows up when our navigators are working with that member. So then if they're working with the member, now they can refer to them by the pronouns that they have chosen. And there's a lot of other examples of how we personalize the member experience in that way. But essentially when members give us that information, it really just goes out to all of our outreaches to our members. All right, and I think that that's my last slide. Right, any questions?
Do you have any data on increased access to any of our demographics? I know in our last presentation with Kaiser, they gave some specific examples on expanded providers and things. I know their model's very different than MODA, but.
Yeah, so are you asking about increased access to providers? Is that what you're asking about?
Yeah.
Yeah, I don't have any data right now specifically on increased access to PCPs. I can give a couple of updates that are a little bit more generic. One is one way that we've really dealt with increasing access to behavioral health is through our Behavioral Health 360 program. And I know we did an update on that last month or the month before, I can't remember. But that is absolutely expanding access to behavioral health providers for our members. And it does it in a couple of ways. One, it uses Spring Health, which has a nationwide which has nationwide access to providers. And those providers, the nice thing about Spring Health is that the providers are
we were kind of looking at those over there.
I was just gonna say. We have some people talking in the background. Can you please mute yourself?
Thanks, JJ. Sorry, I didn't want to try and talk over someone. Spring Health is great because it provides a nationwide network. So really expanded access to behavioral health providers. And it's providing access to a lot of BIPOC providers. So providers who are different races and ethnicities, as well as providers who specialize in certain specialties, such as LGBTQ+. And so that's where I see a lot of value in that is one, it's very difficult to get in to see a in-person behavioral health provider right now. And two, especially if you live out in more rural areas, there may not be the type of behavioral health provider that you're looking for. So Spring Health is really providing a lot of additional access there. One other update is on the PCP 360s. One thing we have done recently is added as a PCP 360, the Providence providers in the Medford area and the Seaside area. So those providers just recently came in as PCP 360s. So it's allowing additional access for members to engage in our coordinated care model. Did that answer your question, JJ?
It did, thank you.
Yeah.
We have Tom.
Can you hear me this time?
Yes,
Yeah,
thanks,
loud
Tom.
and clear.
Okay. So the question that I had has to do with how many you showed the SOGI or the real Real D and talked about the SOGI form for members to fill. What percentage of your OEB membership have filled those forms out?
Yeah, so right now, not many, Tom. So right now, the way that we're driving members to those forms is when they're working with one of our Care 360 staff. So mostly it's members who are coming in through our pre-D program. So then when they're coming in and working with a case manager or lifestyle coach, especially through the pre-D program, that health coach then sends them over to the dashboard to complete those forms. And I don't think that many members are going in and finding those forms on their own right now. So we're actually in the middle of developing a campaign to bring awareness around our new member dashboard. And these forms will be one aspect of that. Another way we're trying to increase awareness of them is when we're meeting with the entities and we go over the new member dashboard and we go over those forms. And so I know a lot of the entities have really been excited about those forms. So we're hoping that they will also help us get the word out.
It would be helpful, I think, for us to have as a report maybe an annual percentage of adults, let's say. I'm not going to go deal with the kid issue, but an annual report of the percentage of your adults who have completed those forms.
Yeah, great. And you know, Tom, we also in our Moto 360 report, and I saw it just went out today too, we do have a page in there that shows you the results of all of that data that we have. So all the SDOH data, which includes coming in from those forms. So it's telling you how many OEB members have income security, income insecurity, and as well as some other points on there. So I'll actually snip that and send it over to you as well. But definitely agree, we should be reporting on how many are completing those forms and what we're pulling from those forms as well.
Thank you.
And I see another hand up, but I don't know who it is.
Michelle.
Hi, I am most interested in the member experience of having to pay for healthcare. So like, I'm just curious, and maybe I missed it, but why the member experience survey doesn't include questions about the cost of care, about whether high deductibles or out-of-pocket expenses are a barrier to getting care for members, and also just information about member satisfaction relative to how much they needed to use their health insurance. Because certainly in my personal experience, the more I need healthcare, the less satisfied I am with my health insurance company.
Okay. Yeah, those are great points. We do not have those on our survey right now. They may be questions that are on the CAPS survey, but I don't know off the top of my head. But I will look into that and follow up with you on that as well.
And Michelle, this is Ollie. We actually do include questions along kind of the same lines as those in our member survey, and we can send you the latest survey results and get your input on those questions.
Thanks, Ollie.
Thanks.
Yeah, one of the challenges with that question in a structure like OEB is a lot of it is determinant on contributions at the member level, and it's different in every entity. So, you know, what we do at Joseph County is maybe very different than what you do in a school district in Eastern Oregon versus Portland versus wherever else. So it's a bit of an apples and oranges question.
Yep.
So it's hard. Although your point, Michelle, is very well placed, because I know I'm the same way. The more I have to use it, the more I'm like, oh, that's painful. Do we have any more questions for Moda?
Great.
All
Well,
right, thank you so
guys very
much.
Yeah, thank you.
Okay, well, that is about the end of our meeting. Do we have any public comment today?
No public comment.
Okay, well, with that, I will adjourn today's meeting and we will see you all in a few months. Thanks, everybody.
Thank you.
Thanks, JJ. Nice work.